Hello everyone, greetings from Pandit Hospital. Today I am going to present you an interesting case of previously operated adenomyomectomy with current size of the uterus of around 18 to 20 weeks. Patient has come all the way from Kolkata to get operated from us. So here you can see entire bowel and the uterus was stuck to the anterior abdominal wall. Patient also had the history of tuberculosis and large adenomyoma operated at least 5 years back. After that, she received all the GnRH analogs for multiple times, but the size of the uterus was not reducing. So finally, we have taken the decision of the adenomyomectomy. Here you can observe entire sigmoid has gone and stuck to the uterus. You can also see the left ovary was densely adherent on the lateral pelvic wall. So our plan is to remove the left-sided tube and the ovary. Previously, she had undergone the cystectomy. We have shifted from the shearer to the harmonic as ultrasound energy here helps in creating proper plane with a good hemostasis. Try to observe I'm using just the tip of the harmonic to dissect and create the plane. So these are the bowel adhesions. That's the appendix epiploidy gone and adherent over the tube and the ovary on the left side. So with the just step of the harmonic, we are doing the adhesiolysis, which are going to help us to create a proper plane. These are the kind of dense adhesions which we are supposed to tackle. Here, the bowel also gone and adherent on the posterior surface of the uterus. Two challenging things here are the bowel adhesions as well as the uterus has gone and stuck anteriorly to the anterior abdominal wall. So this here you can see the entire serosa has gone and adherent on a posterior surface of the uterus. This can be avoided if previous surgery they have used the adhesion barrier. Adhesion barrier sometimes will prevent the adhesions as well as create a plane for the next surgery. So if patient requires the another surgery, you will definitely get a plane between the bowel and the uterine surface. We are moving ahead and we have separated the sigmoid over the posterior wall. Now we are going to inject the vasopressin into the uterus. We are using the dilution 10 unit in 200 cc. We are going to repeatedly use the vasopressin if required, but try to inject maximum so the volume at initially. The half-life of the vasopressin lasts from 20 minutes to 45 minutes. Another thing here, we are putting the vaginal manipulator, but as the size of the uterus is so large that we cannot dislodge the entire uterus. Here you can see the thick pus is coming out from the tube. We have sent this entire tube and ovary for the histopath along with the uterine tissue, which comes out to be the tuberculosis positive. So we are now chopping out the tube as well as the ovary. Watch how I'm activating the active blade of the harmonic and just sliding over the adherent portion. So you can choose the depth of the dissection by doing the same. Now we are working on a lateral pelvic wall. The two things important which we are supposed to identify is the ureter and the bowel lumen. So observe with my left hand I'm giving the traction and activating the harmonic blade and slicing over the plane between the uterus and the ovarian tube which has formed the tumors. So we have completely dislodged the left-sided tube and ovary, and we are progressing ahead to mobilize the uterus first so that when we take the incision laterally, transversely on the uterus, we should properly mobilize and take the suture without damaging any vital structures on a lateral pelvic wall. So this is the anterior adhesions. Take care that you should dissect exactly between the bladder and the uterus so that you should not inadvertently damage the bladder. Now we are gripping the IP ligament and dissecting. Still, there are dense adhesions between the uterus and the lateral pelvic wall. And again, here, as we are dissecting on the uterus, you can see the pus-filled pockets are opening up as patient has received multiple times GnRH analogs and all the oral GnRH analogs for a quite long time, like 2 years, 3 years. That's why all this endometriotic material also undergone the liquefaction and causing this pus formation. It's the both the component are working together, that is the tuberculosis as well as the prolonged use of the GnRH analog. Here we have to see the rectal lumen. So for that we are chopping out all the fibrofatty tissue which is over the lumen. So you can observe here it's all the inflamed and endometriotic material. So that's the ureter which is completely engulfed because of the endometriosis as well as the previously operated surgery. So this is the vascularity around the ureter. As we are not going for the radical surgery, I have just done the adhesiolysis which is needed at the present moment. If we are planning for the complete TLH, we have gone and completely done the adhesiolysis till the level of ureteric tunnel. And another thing is that patient do not have any complaint bowel or the urinary. So we are just taking out all the inflammatory tissue which is over the rectum and on the uterocercal. So this is all the inflamed tissue along with the endometriosis which we are shaving off over the bowel. Similarly, this adhesiolysis is also helping us for the mobilization of the uterus from the anterior side also. Now we are planning to take the incision on the uterus. We are going to take a transverse incision for the adenomyomectomy. The difference between the adenomyomectomy and the myomectomy is that you are not going to get a proper plane here. So if you remove up to the 50% or slightly more than that adenomyotic tissue, that is more than sufficient, because when you are trying to take out a lot of adenomyotic tissue, the rest of the uterus becomes quite weak. So your aim should be to reduce the pain as well as patient should conceive without damaging the uterus. So this is the transverse incision we have taken. We are going to create a flap anteriorly and a posteriorly, or a superiorly or a inferiorly. When we are going to create the flap, our intention is that we are going to leave at least 0.5 centimeter distance from the serosal surface That means the flap should have at least zero point 0.5 centimeter distance from the serosal surface. Below that, on the adenomyotic tissue, we are going to chop. So it's quite big uterus, around 18 week size. So we are taking out layer by layer adenomyotic tissue. Initially, we are using the ultrasound, then we have shifted over the bipolar shearer. When we are using the current, always try to use a bipolar cutting current, or you can go with the monopolar so that you can scoop out the adenomyotic tissue. Important thing is that after removing the tissue, two layers, that's the anterior layer and the posterior layers, we are supposed to approximate. For the approximation, you have to take out layer by layer myometrium. Here you can see as I'm cutting, the pus is coming out through the myometrium. That is because of the adenomyotic tissue which has undergone and received quite GnRH, as well as she had the history of tuberculosis. So both the component working here. So again we are separating between the rectum and the uterus so that we can create a posterior flap for the suturing without damaging the sigmoid. So this is the central portion of the adenoma which we are going to take out, and now we are going to suture first the basal layer and then in a flap manner I'm going to close the anterior layer with the posterior layer. Observe, I'm taking the serosa, going deeper over the myometrium to avoid creation of a dead space. Now again the serosa muscular layer and going deep over the anterior serosal layer so that the dead space creation can be avoided. So this is a bit of flap technique. I'm not doing the flap fixation, anterior flap fixation inside the posterior flap fixation. That is a complete double flap or triple flap technique. Here it is not possible to do the same. We have shown the triple flap technique in our previous videos. So we have significantly reduced the volume of the uterus along with the adhesiolysis and left-sided salpingo rectum. Thank you.
Goodbye.